Hello, and welcome to our first episode of It Takes Guts podcast, brought to you by the American Foregut Society. I'm Dr. Caitlin Houghton.
And I'm Pratik Sharma from Kansas City. Caitlin and I are your hosts for this podcast. The goal for this podcast is to bring gastroenterologists and surgeons together to discuss common foregut conditions, and we are delighted to host this for you today.
Yeah, we're going to explore disease processes from both perspectives of surgeons and gastroenterologists to kind of gain understanding and hopefully come to consensus on when patients transition from medical treatment to more invasive measures. Today, we're joined by two experts in the treatment of GERD, gastroesophageal reflux disease. It's going to be our topic today. And that is a really broad topic, but I think in the spirit of AFS, talking about this disease process that, has really been one that both the gastroenterologists and the surgeons kind of hold dear to their heart. We're excited to have two of our guests, Dr. Trip Buckley here representing our surgical perspective, and Dr. Felice Schnoll-Sussman, who is representing our gastroenterologist perspective to really discuss treatment measures for this disease.
Felice and Trip, say hello to the audience.
Hi, this is Felice, and Caitlin, my last name is so hard to pronounce. So it's Felice Schnoll-Sussman. Every day it gives me problems. So, you are not the first.
Yeah, sorry.
I too have a very difficult last name, Buckley, but it's something that you can figure out over time.
Okay, well, Trip and Felice, welcome. Felice, I'll start off with you. Besides having this long name and which may be hard to pronounce, tell us a little bit about yourself and your practice.
Well, I am a born and bred New Yorker, and the accent that you hear is actually Brooklyn. Just in case anyone wanted to know, that's where it's from. I practice at Weill Cornell in New York City, and I've been there for almost going on 2 decades, actually. And I actually love my practice. I have a lot of fun every single day. And I would say the vast majority of my practice is limited to patients with diseases of the foregut. Most patients with esophageal diseases, but also those of the stomach and the small intestine and whatnot, and patients with hereditary cancer syndromes. And I'm an advanced endoscopist. So I really see the full spectrum and have the opportunity to treat the full spectrum of disease from benign to malignant, and transition patients from both the consultative type of arena to the advanced endoscopic perspective as well.
It sounds like you have the classic foregut practice for a gastroenterologist and ones that I know that we see as surgeons. We work closely with you guys, so excited to have you here today. Dr. Buckley, tell us a little bit about your case mix and your practice.
Sure. Well, Trip is just fine. I'm at the UT Austin Dell Medical School here in Austin, Texas. I have pretty much of a foregut only surgery practice, and by foregut, I mean non-bariatric foregut, so dealing with esophageal disorders, stomach disorders. And from a case mix standpoint, I mean, it's the full gamut from some diagnostic things. We certainly have in-house gastroenterologists, which is actually unique. So I'm in a digestive health clinic with gastroenterologists whom I practice with every day. So we've got 2 full manometry systems, and we each do testing and our own reads of those tests all the way through advanced endoscopy and then of course surgery. And so it's been an exciting time. I was actually inspired to go into surgery and this particular type of surgery from a gastroenterologist whom I did research with even before medical school. Many of the GIs might know this individual. His name is Gene Overholt, so inventor of the flexible sigmoidoscope. So it's been a journey for me, and I've finally achieved my dream of getting GIs and surgeons together in a single practice and working together to have the best outcomes for our patients.
Okay, thanks, Trip. Now that we've heard all these wonderful things about our panelists, let's put them to work a little bit here. So Felice, let's start off with you and, get a little bit more about gastroesophageal reflux disease patients. And by the time these patients get to us, Felice, they're either not tolerating the medical therapy, they're not happy with the medical therapy, or the treatment's not working. So can you tell us a few things about the shortcomings of medical therapy?
It's interesting. I agree with you. One of the things about being a gastroenterologist that specializes in esophageal diseases is that very often patients have been on multiple medical therapies, not one proton pump inhibitor, but two, three, 2 times a day, 4 times a day. Some of them have had multiple endoscopies. And, so these are not the patients that come in and start on medical management and then are fine and walk away. What that allows for us to have is really, really sort of stretch ourselves. And I think one of the first things is deciding, does someone not actually have GERD at this point in time? Because as you know, and I'm sure everybody on this call knows, that patients can get labeled with diseases. They can get put onto one of these medicines for a variety of reasons. They were in the emergency room for something and they were put onto a proton pump, but they were told that they have reflux, and it's not actually even the diagnosis that's at play. So for one of the things that's really important in my practice is nailing down the diagnosis. Does someone have reflux disease? And as a consequence, if the medications are not working, then what other diagnosis perhaps is at play, even if it's still reflux, and also what other options are available to them at this point in treatment.
Okay, great. Trip, just for you along those same lines, traditionally, gastroenterologists have been the ones sending these patients to the surgeons for consideration for anti-reflux surgery or some other minimally invasive procedures. Do you get referrals directly from primary care physicians or ENT surgeons, for reflux, or is it primarily through gastroenterologists?
No, I would say it's primarily from gastroenterologists and or the patients themselves who have been around the medical block, as it were, and just haven't found the answers they're looking for. So those are the predominant ones. Certainly ENTs, makes up a big part, and as well as pulmonologists. But yeah, that's the predominance of our practice. And I do just want to give a shout out to Felice from the testing standpoint. I mean, I think that so many people get labeled with GERD and no testing has been done. And testing is the crux of, figuring out how best to treat these folks and figure out how severe their disease is, what their disease burden is, and nailing down that diagnosis.
Elise, as far as a gastroenterologist perspective, when a patient first comes to, and I know you're not a general gastroenterologist, but kind of if you could answer this, if they come to a gastroenterologist complaining of acid reflux, how often are they just being put on a trial of PPIs, and how often are gastroenterologists doing objective testing beforehand? And what kind of drives that decision making?
So I would say that from even some, general GI, it's very rare for a patient to present to a gastroenterologist, general GI, without having already been on a PPI. And most of that is because they're over-the-counter medications, and direct-to-consumer advertising is an enormously powerful thing. And you can't go on a bus or a plane or a train or read a newspaper without seeing advertisement regarding these medications. So the patients themselves are treating themselves because they don't need medication. They don't need a prescription necessarily. I think the big, more important question is people who've been sort of empirically treated for reflux disease. Why are they not good at that point in time? And so one of the things that's really important for me is to make sure, are the proton pump inhibitors optimized? Because very often patients come in, they say, I'm on X, Y, and Z medication. And then when you start to really ask them about that medication, they're taking it maybe as needed. They're taking it before they go to bed. They're taking it with their meal. So just being told that I'm on a PPI is really just a small nugget into that. And I, of course, then start to question them and educate them on, are you taking this medication? And optimally would be a half an hour prior to your meal to make sure that they're taking it the correct way, to really assess whether or not that medication has failed them, right? Because very often they'll come and say, I take PPIs, they don't work. And that might not necessarily be true.
And then once you have them optimized with medications, how long are you going to give them as a trial of PPIs to see if they actually are working for the patient?
So in general, in our practice, let's say, or even a general GI practice or my practice, I'm going to discuss with them, are you taking it? And then I'm going to put them on a 2 to 4 week course. I mean, that is really what I am, thinking of now. The reality is, in terms of, let's say, if we think someone, that's if they've come in on the medications, right? If it's brand new, I might give longer to assess healing of erosive esophagitis. So I feel if they come in naive, never seen a medication, very, very rare, right? That is just very rare for us to see those types of patients. But I might give them an 8-week course of the medication, make sure that they're optimizing it, have a conversation with them about lifestyle, dietary changes, what are they doing, all those other things which we might get to at some point in this conversation. At that point in time, that's when I'll reassess, is this medication working or is this medication not working?
Are you doing an endoscopy at the same time, or are you going to wait until you see how the meds work before doing it?
Okay. So some people would say you go to a barber, you get a haircut, right? And so you go to a gastroenterologist, you might wind up getting an upper endoscopy. I think that is probably true. And the reality is this: our diagnostic tool is the endoscope. I mean, that is the reality. And if patients were well and did great on the PPIs, like I said before, they wouldn't be seeing us. So the reality is they probably have earned an endoscopy by the time they've seen a gastroenterologist. What they've not earned is probably 5 endoscopies, right? If they've had 5, we don't necessarily want to go on with that. But I would say if someone had been previously empirically treated with a PPI without objective workup, I would make sure that it's optimized. If they have unsatisfactory symptom relief, then I would do a diagnostic upper endoscopy. And at that point in time, I would do it typically off of the PPI for 2 to 4 weeks.
Trip, you mentioned about diagnostic testing, and that was the word both of you have been using for a while now. So let's get into testing now. And so, you mentioned your different referral patterns. Let's say it's an ENT surgeon or even the patient who's gone through the medical part and comes to you, and you're evaluating the patient. What are the different types of diagnostic testing? Now, let's keep endoscopy out of the way. Hopefully you're leaving that for the gastroenterologist. What are the diagnostic testing are you considering?
Yeah, sure. Great question. So often patients have had an endoscopy by the time they've seen me, and they may have had those 5 endoscopies before they see me. But at the end of the day, if they're coming in for GERD, we have to have objective evidence of GERD. So we need a pH test at a bare minimum. If they've just had an endoscopy, we will just go ahead with a unsedated Bravo and high resolution manometry. Sometimes patients don't want that or not going to tolerate that, in which case we will repeat the endoscopy and do a pH study. But that's our go-to is the Bravo. Occasionally we'll do 24-hour pH impedance, but our go-to test is off PPI, 48 or 96-hour Bravo.
Okay. Felice, I know you don't like surgeons that much, but when do you consider sending your GERD patients for surgery? I mean, let's assume here's a patient who is doing well on PPI therapy, or you've documented reflux. So let's talk about documented reflux. We all agree that we need to ensure that the patient actually has reflux, because if the patient doesn't have reflux, this podcast is over. So let's assume there is reflux. When would you send that patient to be seen by Trip?
I want to clarify something. I love my surgical colleagues. So I'm putting it out there, and you can put that on repeat. And
in particular, me.
In particular, Trip, Caitlin, all of that. And because let me be perfectly honest with you, it takes a village to take care of these patients. And so any gastroenterologist who believes that they can do this without a surgical partner, they are not practicing the best medicine. So I'm just putting it out there. Now, when would I refer someone to a surgeon? I would say that I probably have the conversation about surgery with every single patient. With every single patient at some point in time. It might not be in the first conversation, but at some point in time, if I am still seeing someone on a proton pump inhibitor, especially if they are not, achieving optimal results, but even if they're on maintenance therapy, given the environment now, given the conversations related to medications, related to PPIs, given the advancements in both our endoscopic surgical approaches as well as surgical approaches, I believe that with personalized medicine and with an intention to treat a patient as an individual, you should give them every option. And so for me, I have in my conversation the fact that surgery is on the table potentially for everyone. Now, who wouldn't it be? So if I have someone who comes to me and they're at extremes of age and they have comorbidities and they are well enough on their PPI, I don't start having a conversation about an elective surgery because the reality is this, the risk for them is higher. But if I have a young patient, and by young, I mean, 18-year-olds to even 70-year-olds that look great or even higher than that, and they are well and they are enjoying life and they have good quality of life, but they are not happy to be on medications, or their symptoms not well controlled, or they're fearful of medications, then I have a conversation with them about the different options. And what I do is I allow them to go to speak with a surgical colleague and to meet them and to hear from them also, what would this entail? What would life potentially be like? What's the possibility of it not working? What's the possibility of redo? All those other things that we speak about, potential for gas bloat. And I allow them to really be a part of the decision-making as well.
If I can just comment on that, I mean, that's a really enlightened approach from a gastroenterologist, but it's not surprising coming from Felice because her mentor is Phil Katz, who wrote the guidelines for the gastroenterologists, and they're being updated now, and I'm not privy to what they're going to say, but in the guidelines for treatment of GERD under surgery is that surgery is an option for patients on long-term therapy on PPI. That's like 40 million Americans. Surgery is as effective as medication for treatment of GERD. It really should be more effective based on the latest data, but nonetheless, that's what it says. But most gastroenterologists don't treat to the guidelines. And I think that's, frankly, we can get into this later maybe, but that's the fault of surgeons. And surgeons have not controlled our own quality in terms of results and outcomes in terms of the procedures that we have available to us. And so I think it's really on surgeons to reach out to their GI colleagues and say, hey, I'm an expert in this. These are my outcomes. We should all know our outcomes. This is what I offer, and this is how we can team up to take better care of these patients.
So Trip, can you tell us that? I mean, so you're talking about outcomes. We all know outcomes with PPIs, but you mentioned outcomes. So tell us some outcomes of results with surgery. How good are they? Are they durable? Does it matter who's doing the surgery as opposed to a PPI, which can be given by anyone? So can you tell us and share your thoughts about that?
Yeah, sure. I mean, in general, there's multiple prospective randomized trials of, usually it's the classic Nissen, but there are trials out there looking at TIF, looking at links, and compared to PPI therapy, there's a great trial looking at links versus double dose PPI therapy, meaning patients who are not optimized on single dose. All of them supports the surgical option. To your point, it doesn't matter who's doing it. Of course it matters. And it really matters. It's one of those surgeries, much like esophageal cancer surgery or pancreatic surgery. You have to go to somebody who knows what they're doing. So we think that number is doing at least 25 a year. My practice has been over 200 for the last 10 years, but 200 cases, anti-reflux cases a year. But it probably takes about 50 to get good in your fellowship and residency. And then you need to, do a certain volume to stay good at those cases, because, the fact of the matter is fundoplications are hard. Links, and there's some other enabling technologies that make it easier, but you got to still make sure you understand the disease process so you're picking the right patients. And as Felice alluded to, you're really trying to look at, the phenotypes that are going to benefit from certain surgeries. So I think that's hugely important. How do you follow your outcomes? Well, you can look at a lot of different things. I mean, first of all, we follow our patients forever, and I recognize that's probably not in every practice's capability, but you can look. We always get GERD HRQLs, so GERD HRQLs are out in the literature a lot, but we get a GERD HRQL on everybody, and then we get it 6 months after surgery, and then at a year, and then every year thereafter. So we can track our outcomes, and I can tell you that on average for our practice, our GERD HRQLs, and it's been, classic over the last 10 years that we've been following them, is on average, we take a patient from a GERD HRQL of 26 and bring them down to 6. And our last cohort of 500 patients, it was 3. So we want to look for those patients in whom we can have that huge delta in their quality of life that they're just not going to get with a PPI.
Just to add to what you're saying in terms of the phenotypes, when I'm looking at the patients in particular, the ones that I actually say to myself, I'm going to even early on start suggesting surgery, those are really the ones that have persistent or troublesome GERD symptoms and have severe reflux. So the ones that I do the endoscopy, they have LA grade C or D esophagitis, and the ones that actually have the large hiatal hernias. I know that the PPIs are just not going to necessarily hit the mark on that patient population. And that's really probably where our surgical colleagues are going to play a huge role in managing patients that are just at times extraordinarily symptomatic.
Felice, to that point, I think, what surgeons have seen, I guess, is that, or the frustration that we've seen between surgeons and GI doctors is sometimes that, we feel like we've evolved and we're starting to treat patients based on the phenotype. We're not just using the Nissen anymore. We have other options like LINX and Toupet, and we're trying to really personalize surgery for the patients. And we feel like our outcomes are better than kind of the bad rap, so to speak, the bad rap that the Nissen had with a lot of gas bloat and aphasia and the inability to burp and vomit and all those side effects that, it seems like in the past gastroenterologists really kind of held on to. Well, because of those, we think surgery isn't a good option for our patients, and that maybe it's a failure to refer to surgeons. I don't know if that's old thinking, but that's kind of what maybe surgeons feel that the gastroenterologists are thinking.
Sure. Well, I can tell you, just being on this podcast, and the ethos of the American Foregut Society is to dispel those things, right? And so the way that it happens is through conversations. Now, one of the reasons why I might be enlightened is because I actually work in a practice setting where I work arm in arm with my, foregut surgeons, and we discuss cases, we share cases, we talk about the phenotypes, and we do this exact thing. I start the conversation with my patients when I'm talking about surgery. I know about the surgeries. And so I think it's my responsibility, even as the gastroenterologist, to understand the surgery so that when I send my patients to surgery, I consider it in my mind that I'm teeing them up for the surgeons. And I make sure all the testing is done. And then after that, I start discussing with them what are the different surgeries that the surgeons is potentially going to start talking to them about. And that really helps the patients as well. They don't go there first hearing about it because they trust us and they've been with us probably for potentially years. And that recommendation makes a big difference. But what you're talking to is exactly important. And so, for instance, in our patients that have, let's say, regurgitation, who have failed medical management, that is really where I'm thinking about magnetic sphincter augmentation, because I know in that patient population that technique really is going to be very helpful. In my patients that are obese, that have been thinking about having obesity surgery, I'm going to talk to them about a Roux-en-Y gastric bypass, because that would then probably really heal all of their problems. And now not only are you taking care of reflux, but you're taking care of probably the bigger killer for them, which is obesity. But you're exactly right. If we only think about this as reflux surgery and going for one specific surgery, that's not good. And what I rely upon is that my surgical colleagues also then are able to offer the gamut of surgery, because I think where you get into trouble is potentially a surgeon that's a one-trick pony. They know one thing, they do it, and they don't know how to do a LINX, which means they might not offer a LINX, and then potentially, we're not optimizing, the patient care. So I think that's kind of where AFS plays a big role. And also what's really important is that our surgeons have evolved also to realize they have to do everything. Like they have to, or at least maybe even refer to one of their surgical colleagues if they don't, right? I don't do LINX. Let me refer to, someone who does. I don't know, but I think that's really where we end, this kind of bad rap of surgery.
And Caitlin, partly, I think your question also pertains to the type of practice and the expertise, right? Is that here we are talking about all expert centers, expert gastroenterologists with access to everything. But at the end, also, we have to remember that GERD patients are seen all over the country, from the rural areas to New York, and so what may be available there is difficult. And plus, one size doesn't fit all. So unlike Felice, I don't think I'm personally so proactive about surgery in every patient I see. If there's patients who are taking medications 3 or 4 times a week and they're happy with it, I don't see any reason for them to be seeing a surgeon or even discussing
Great.
surgery in that patient population. So it's all, as you mentioned, it's individualized now. So we have to identify which of those patients, not the 40 million Americans, not everybody needs surgery, but which are those patients who need surgery. So Trip, going to you, you mentioned about some aspects of surgery and some pre-op testing. Was that it? Are there any other specific tests that you require prior to surgery that you would want the GI colleagues to be thinking about before sending them over to you?
Yeah, and just before I hop on that, I'll comment on yours, which is, I think it's really important. It's looking for that huge delta in quality of life. So while the guidelines might say it's an option, every day when I'm in clinic, at least once a day, I tell someone, hey, you're doing great on this PPI. Dementia is not really a thing. I go back to what my mom taught me when I had my first child, which is you can't make a happy baby happier. So if you're doing well, keep doing well. And we'll reserve surgery for later, or if you start to have breakthrough symptoms. And so I think my actual practice is not to just operate on everybody that's PPI dependent, but really provide that education around and dispelling some of the bad news about PPIs, and then understanding where they are in their goals for their reflux disease and how the best way to treat it is. So back to testing. I mean, we get an esophagram on everybody. We have a specialized marshmallow bagel swallow that we do on every patient. Again, every patient needs to have an endoscopy. Does everybody have to have a pH study? The answer is no. I mean, again, if you've got Barrett's esophagus, that's clear objective evidence of GERD. If you've got LA grade C or D esophagitis, I consider that objective evidence of GERD. I don't operate just straight out of the gate on everybody that's has LA grade A or B, but if you're on double dose PPI and you've got LA grade B esophagitis, I mean that you've got GERD. But usually we end up getting a pH test on many of those folks.
Okay, thanks, Trip. And for our listeners, this is the It Takes Gut podcast from the American Foregut Society. And just listening tells us about the importance of this multidisciplinary approach to patients with foregut disorders. I'm going to turn it over to Caitlin for any final concluding remarks. And what does the future hold, Caitlin?
Well, I think one of the biggest things that we've kind of learned is that it does take the village, as Felice said, and really by working together and kind of understanding that transition of medical therapy and when it's appropriate for a consultation by a surgeon, and really individualizing it towards the patient's need. And then also having that multidisciplinary approach. And I think the AFS is trying to enforce that, or not enforce, but really try to foster those relationships. And we hope that by listening to this conversation, you can start fostering that relationship with your GIs if you don't have them already, or from a surgeon or GIs to your surgeons, and making sure that you do partner with each other to really make sure our patients have the best outcomes possible. Well, thank you both, Trip and Felice, for taking the time to talk with us today. And we look forward to our next episodes. Please stay tuned for the whole series. We'll have exciting topics ongoing throughout the next couple months. Thank you.
Thank you for having me.
All.
It was wonderful. Yeah. Thank you so much.